to where we started, which is getting people better. So I spent a lot of my time, introducing technologies and applications that, might be new to some people, but also on the integration side of things. And I always like to tell a few stories, but how do we know it works? How do we know it doesn't work? So using evidence-based practice is a really good first step, is finding out what the best literature is out there, but also knowing that it changes. So I use this example. I was giving a seminar and we were talking about decompression and on low coefficient friction design tables. Um, it's not the same as like where a lot of this started back 20, 30, 40, 50 years ago. Actually, decompression or mechanical spinal traction dates back some 4,000 years. So it goes way, way back. And, the technology has changed as such where, I don't need to use 50% of body weight anymore. And I had a attendee come up to me at one of the breaks and she says, just because you say it, it doesn't mean that I'm going to stop doing it because that's how I do it on this particular platform, which was actually the one I was talking about. And that's fine. The cool thing is that, if you're getting the outcomes, then that's one of the factors, one of the KPIs, key performance indicators that you want to consider within your clinic setting. And that'll be my first kind of pitch to say, you got to collect data because we want to know that whatever it is that we're doing is working and what doesn't work because it's certainly about the patient satisfaction, it's about the outcomes, it's about your workflow, it's about your efficiency, and again, all these different factors. Another example, I was doing some traveling and I went to one manufacturer on laser and I asked about, well, when would you use something else? And she said, well, I only use laser. Okay. And then in that same trip, I went to a manufacturer of Shockwave and I said, when would you use something else? She said, well, I only use Shockwave. And like you gotta appreciate a commitment to something, but I think that can close mind us a little bit in terms of when something new comes out. It doesn't mean we need to run and just gravitate towards the new shiniest thing that comes out. But the funny thing is, like both shockwave and laser, they've been around for a while. They're a little bit newer obviously in this country than when I was in Europe. Pickleball, I'm going to save till the end because that seems to be one of my common themes in all of my presentations lately because it's an interesting thing to talk about, think about, and work with. So Monday morning take home, and again, obviously I'm talking about treatment modalities, and that can include manipulation, adjustments, all the way to laser, shockwave, and whatever. Um, but what's important is sort of that commitment. So knowing how it works, knowing that it does work, and why it works, and that's part of that implementation. And I just remind people that that's not enough, right? Where think about the other things that you're already implementing in clinical practice and what seems to bring people back. Like that doesn't change. Like we need to make sure that we're committed to something. And again, one of the recent conversations was the clinician reached out to me after reading one of my articles and was sort of asking about am I a bad person because I'm trying to do some of these other therapies that are costing out of pocket expense to the patient, and my staff is thinking that I'm just trying to get money. And I'm like, well, no. And I said, potentially that has to be a deeper conversation to whatever it is that you're doing, because they're really our first line. Like if you're the clinician, I'm sorry to say, but you are not the person that everyone is coming in to see as much as we think they are. And statistics show it's really your staff, especially the front office, and how they're communicated with and their satisfaction and following up and things like that. So it's hugely a team effort in creating those enthusiastic patients and really committing to whatever it is that we do. And again, I think everyone starts with that base level of whatever we were taught, in school, and what the crux of, if you're a chiropractor or an outpatient physical therapist and you learn manual therapy as one of your mainstays, then you're definitely committing to something like that. And in fact, like for me, patients will ask, like, well, do I have to do that? And 99.9% of the time, the answer is yes, because of how I practice and what exactly that I do. But first is like realizing why patients are coming in, how we're able to keep them, and really how we're supposed to get more patients. And so I've said this in the past too, is like, my thought process was, patient comes in, bang, bang, boom, get them better, discharge them, you never see them again. Well, especially when you live in maybe rural New Hampshire like I do, you'll run out of people. You'll run out of patients, you'll run out of customers or members as we like to call them. And so that's where, we provide them a really good patient experience, and we do our job that first time. And then we have some other things to offer them during, those downtimes where they're not experiencing some of those problems. And then even think above and beyond that, like how can we do one step better? I just wrote a piece on like what's coming up with spring, and in my neck of the woods, we have a lot of people that, start going out and swimming and playing golf and things like that, and how, we can address that. And it doesn't have to be necessarily the professional golfer. I mean, if you're a golfer, you know that playing golf better is more fun for most of us anyway. And I like to joke and say, well, I get more bang for my buck because I get to hit the ball a lot more than other people on the course. But in any event, not having back pain while swinging the club, and being able to swim, do your triathlons, getting outside and moving around is really part of that. And in that framework is this multimodal approach and what it is that we have to offer, with our patients. So studies are actually pretty clear that the one hit wonder just isn't there. Like there's not one thing that we can typically do that addresses all of these problems, especially at the different stages that patients may enter. So studies show us that we do get some faster recovery. As a result of that, we get fewer visits. Now, there's a caveat to that. And I actually had a participant raise their hand and they're like, well, why would I want to do that? And because I'm going to make less revenue if I don't have as many visits. And it's like, well, here's the thing. Shorter visits get people back to work sooner. But it also means that their patient satisfaction is higher. Not an opinion, but that's what the literature shows us. And so as a result of that, that has implications to them coming back when something else goes wrong. And let's face it, we're human. Something is going to go wrong again. Maybe it's a new thing, maybe it's a reoccurrence, whatever that case may be. The other thing is that as a result of that high patient satisfaction, they're also going to be more likely to refer patients to us. So in the outpatient space, whether you're chiropractic or physical therapy, it's still direct to consumer marketing. Now, if you're in an outpatient, you're getting referrals from surgery. That's a little bit different. It's actually a very different model, and it even makes it challenging to offer some of these services that we're talking about, because you're more likely confined to what insurance is paying. So I want to like kind of cover like the physical agents briefly. Like we could spend 8 hours on this, but to kind of help set the basis of the decision making process. And so the physical agents that we're referring to, also called modalities, physical agents and modalities is the more inclusive term, and that includes the myriad of things that we do, as far as endogenous forms of treatment, things that we do to someone to create something. So it influences biochemically, it influences biomechanically, and as a result of those things, we can enhance and create a more optimal healing environment and opportunity as a result of that. And again, the studies are pretty clear on that, and that a multimodal approach may often mean more than one, right? And I'll consider within that framework sort of mobilization and manipulation as well. I didn't put that in the chart here because I'm pretty sure everyone's up to speed on that. So this is not all inclusive, but let's look at laser therapy or photobiomodulation. The highlights are it works extremely well from a biochemical standpoint. And especially if you think about the biochemistry that it really influences, is more during those early stages. And we'll come back to that in a second. I don't want to dive too deep into all of this, but metabolic activity, which is typically not devoid, but in some patients it is devoid of what's going on, and so it really helps to accelerate that early phase process. The other things is it also helps to reduce inflammation. So if we think about even that chronic patient that came in with the acute exacerbation, it really addresses those early sort of conditions. Shockwave therapy, extracorporeal shockwave therapy, whether it's radial or focused or defocused deep, we say it breaks down. It doesn't break down anything. Nothing we do is destructive. What it creates is an environment where resorption typically takes place, whether it's calcification, certain fibrotic tissue, and things like that. It is really good. Yes. Can it reduce pain? It can. And let me sidebar here for a second. So after I give a seminar, oftentimes, or a presentation at a conference, I'll have someone come up to me from a manufacturer and say, "You got to try our doohickey because it's awesome at reducing pain." I'm like, well, here's the thing. When you look at this chart, one of the things that is consistent across the board is they all have an influence on reducing pain, right? That's why they fall within this category. And so I don't want to say treating pain is easy, but we have a lot of options there. But we need to think about it from the framework of what else do we want to accomplish? Okay. So, yeah, it can, but I got a question the other day about a condition that is highly sensitive, and it probably wouldn't be my go-to because you are in direct contact with the patient, whether it's focused or unfocused or radio. And so that may not be the best option during some of those early stages. And then let me start to throw this in there is like, where does it also fit with your framework in terms of what else do you have to offer that might provide similar benefits at a certain stage where this will shine someplace else? Just start to think about that process. Mechanical spinal decompression, reducing intradiscal pressure, remove space occupying lesions, often within the first treatment, even at multiple levels, improves the neurological response and motor control. So there's a lot of interesting things. And now let's look at some of the limitations too. Is it's for the spine. Although I will argue that if you're treating a hip problem or a shoulder problem, it can also be